So good morning. The topic for today's session is obesity in pregnancy. So the prevalence of obesity has reached enormous proportions globally and also in both developed and developing countries. So it is considered to be a risk factor in obstetric practice. So today we will see what is the classification of obesity, and once the woman is obese, what are the complications that she encounters even she becomes pregnant. And so she always needs a bit of preconceptual care. So what is that we need to advise when she comes for the preconceptual care, and then once she becomes pregnant, what should be her antenatal care, because once she is obese she will have a lot of antenatal complications. So what should be our antenatal care, and then even the intrapartum care should be carefully monitored, because she will be at risk of prolonged labor or dysfunctional labor, and most of the times she needs induction of labor or she lands up in an emergency cesarean section. And then even the postnatal care will be complicated by few of the complications, especially the venous thromboembolism. So what should be your postnatal care to prevent her from going into postnatal complications? So, and to summarize, what are the recommendations in obesity in pregnancy? So obesity in pregnancy is defined as a BMI of 30 kg per meter square or more at the very first antenatal visit. And then these are the three classes with obesity, and they share a relationship with BMI and the pregnancy morbidity and mortality. So coming to the complications, so once a woman is overweight or obese, she will have complications like menstrual disorders, and then most of the times she tends to be infertile, and she needs ART techniques to conceive, because in few of the women this overweight or obesity is complicated by, or they will have a high incidence of PCOS. So the mechanism behind her irregular cycles or the menstrual disorders and the higher rates of infertility is because obesity influences the HPO axis, and these women display shortened luteal phases, and also they have lower levels of circulating follicular stimulating hormone, luteinizing hormone and progesterone, and they will have a high incidence of PCOS, and mostly they require ART techniques to conceive, and even the cumulative pregnancy rates will be a bit low once these women have an associated PCOS. So they always need our advice even before they become pregnant. So it is always advised to lose weight through lifestyle modifications. So they always need weight advice regarding the weight loss, and they need a bit of dietetic advice as well. But women who are morbidly obese or where BMI is equal to or more than 40, they require bariatric surgery. And in case if the woman undergoes bariatric surgery, so pregnancy has to be avoided for at least 12 to 18 months, because the fetus has to be protected against the rapid weight loss that we see after this surgery. So it is always safe for them to avoid pregnancy for at least 12 to 18 months in case if they undergo this bariatric surgery. And then what are the advantages of weight loss even before they conceive? So various studies have significantly quoted that they significantly reduce the risk of antenatal complications like the risk of developing hypertensive disorders of pregnancy, the gestational diabetes mellitus and fetal macrosomia are significantly reduced. And not only that, it reduces the risk of stillbirth, and in case if a woman goes for or opts for a vaginal birth after a cesarean section, there is an increased success rate after vaginal birth after cesarean section. So these are the advantages of losing weight even before she conceives. And then it is always safe for us to give them 5 milligrams of folic acid supplementation, daily one, and ideally this has to be started 1 month before conception and at least continued throughout the first trimester of pregnancy, because these women are at increased risk of having neural tube defects and other congenital abnormalities. So as to prevent them from having these anomalies, so it is always advisable to give them a high folic acid supplementation or high dose folic acid supplementation. It is 5 milligrams, so has to be started at least a month before conceiving and then should be continued during the first trimester of pregnancy. And then coming to the antenatal care. So once they become pregnant, what should be our care? So BMI has to be calculated at the first booking visit, and again these women have to be reweighed at the third trimester. And as a part of routine care, these women should also be advised antenatal screening for chromosomal anomalies. And then because they are at high risk of developing structural anomalies, so screening and diagnostic tests for structural anomalies should also be carried out. And then serial measurement of symphysis fundal height is recommended from 24 weeks of gestation, and also it is better to go for a serial assessment of fetal size using ultrasound, because it is technically a bit difficult once they are obese and the FSH measurements may not be appropriate. So it is better to go for a serial assessment of fetal size using ultrasound. And in case macrosomia is suspected, these patients might need an induction of labor once they reach term. And because they are at increased risk of developing gestational diabetes mellitus, they should always be screened for gestational diabetes mellitus. And then again, the incidence of hypertensive disorders of pregnancy is also increased in these women. So BB measurement should be taken at the booking visit and at every antenatal consultation. Sorry for the mistake. So at every antenatal consultations, she needs measurement of blood pressure. And also, obesity is considered a major risk factor for development of hypertensive disorders of pregnancy. So it is safe to advise to prescribe 150 milligrams of aspirin daily from 12 weeks of gestation until the birth of the baby, so that these women may have reduced incidence of developing hypertensive disorders of pregnancy. And again, obesity is considered to be a strong risk factor for development of venous thromboembolism. So always the risk assessment for VTE should be done during the antenatal visits, and appropriate anticoagulants should always be prescribed to prevent venous thromboembolism episodes in these women. And again, these women are also at risk of developing anxiety and depression. So at every visit, it is ideal for us to screen for mental health problems as well. So the complications that we encounter in early pregnancies include increased incidence of miscarriages, and also there is increased risk of fetal anomalies. So these are the complications that we encounter during the early pregnancy. And also technically it is a bit difficult for us to detect these anomalies of the fetus using ultrasound because of the technical issues that we see in this with these women. So the increased incidence of miscarriage is explained by the hypothesis that there is an increased production of inflammatory and prothrombotic agents produced by the adipose tissue, or these agents are released from the endothelium secondary to stimulation by the adipocyte derived factors. And also it has been suggested that the plasminogen activator inhibitor type 1 is associated with increased risk of miscarriages in these women. So this fact explains the increased incidence of spontaneous miscarriages that we see with these women. And also the increased incidence of fetal anomalies may be explained by the fact that these women have a high prevalence of undiagnosed type 2 diabetes, so almost to the rates of 30 to 50%. So there will be a 30 to 50% prevalence of undiagnosed type 2 diabetes that could be the contributing factor of the increased incidence of congenital anomalies that we see in these women. And also there is a significant insulin resistance without frank glucose dysregulation also in this woman. So both these factors might contribute to the increased incidence of fetal anomalies in this woman. So they should always be concerned regarding these complications. And then the ultrasound and obesity. So like we discussed, there will be always a technical issues with the detection of fetal anomalies, because the adipose tissue in this woman absorbs the associated energy and significantly attenuates the ultrasound signal. That could be one of the reasons for the failure in detecting the fetal anomalies, and also the increased distance of the fetus from the skin surface because of the presence of adipose tissue also might be one of the factors leading to failure in the detection of anomalies in this woman. And then the complications that we encounter during the later part, apart from the early pregnancy, could include vitamin D deficiency. So in women where we found that there is vitamin D deficiency, it is ideal to prescribe 10 micrograms of vitamin D daily. And also, as we have discussed, these women are at increased risk of developing hypertensive disorders of pregnancy, which includes pregnancy-induced hypertension, preeclampsia, and also these women are more prone for developing gestational diabetes, venous thromboembolism, anxiety, depression, and high rates of stillbirths are also seen in these women. And the technical complications during her antenatal period include again a difficulty in satisfactory growth assessment because of the technical difficulties that we see in these women. And also these women require special equipment to monitor, either even the BP monitoring also requires special cuffs for these women. So they always require a special equipment to monitor for these complications. So the mechanism of effect behind the development of hypertensive disorders of pregnancy and the gestational diabetes mellitus could include the high degrees of insulin resistance in this woman, and then there is low grade inflammation and dyslipidemia, and there is alteration in the systemic microvascular function. So various metabolic and vascular factors contribute to the increased incidence of these two complications that we see with this woman. And it almost mirrors that of the development of metabolic syndrome in later life. So a combination of metabolic and vascular factors underlie the development of hypertensive disorders of pregnancy and gestational diabetes mellitus in these women. And also these women always display a pro-inflammatory phenotype with impaired microvascular function right from early in pregnancy, leading to the development of these complications. So as we discussed, the WHO recommends aspirin 150 milligrams ideally to be started right from 12 weeks. It is safer to start them from 12 weeks of pregnancy and continue till birth to prevent the development of preeclampsia in this woman. And then the mechanism underlying the development of venous thromboembolism in obese women is these women display higher plasma concentrations of all the prothrombotic factors, which include fibrinogen, von Willebrand factor, and factor 7. And also these women have high rates of secretion of interleukin 6 by the adipose tissue, and along with the secretion of interleukin 6 in combination with the actions of adipose tissue expressed tumor necrosis factor alpha, they could underlie the association of insulin resistance with endothelial dysfunction, coagulopathy, and coronary heart disease. So this explains the mechanism of development of venous thromboembolism in obesity. And then so it is always better to advise these women to prevent against these embolic episodes, the usage of pneumatic compression stockings before and after cesarean delivery in case if they are going for an operative delivery, and always after surgery they will be advised early ambulation and adequate hydration, and also they will be prescribed thromboprophylaxis ideally with low molecular weight heparin to prevent venous thromboembolic episodes, especially in the postpartum period, because that period is considered to be the highest risk for development of these embolic episodes. And then the intrapartum complications include the high rates of induction of labor in these women, and then high rates of operative vaginal delivery, as well as operative deliveries in the form of cesarean section. And in case if they set into labor, the labor is tends to be dysfunctional, so there will be slow progress in labor. So in a way, the operative risks tend to be higher in these women, and also these women are at increased risk of developing anesthetic risks, and they always require special equipment for monitoring. So the anesthetic risk include the loss of landmarks because of the excess adipose tissue that these women have, so making vascular access difficult. And also there is high incidence of failed epidurals, and then once they require general anesthesia, there is an increased risk of even aspiration, and also there is difficulty with intubation. So I think we can appreciate in this image, though this woman has a large body mass index, but the lumbar spine landmarks and the posture are favorable for giving regional anesthesia than epidural or spinal. Whereas this woman also has almost more or less the same BMI as of the previous lady, but because of the distribution, the fat distribution, the landmarks are not very favorable, and these are the women wherein we encounter high incidence of failed epidurals or failed spinals. So coming to the fetal complications, the fetal complications include again increased incidence of neural tube defects and prematurity, the macrosomia, and then once it is a macrosomic baby, there is again increased risk of having birth injuries because of shoulder dystocia, and hence because of these complications, the shoulder dystocia and the birth injuries that we encounter in these fetuses, there is an increased perinatal morbidity and mortality, and it was also because of the effects of maternal metabolic conditions that these women are prone for. So in case if they develop gestational diabetes mellitus or hypertensive disorders of pregnancy, so there can be at increased risk of having a premature delivery and increased perinatal morbidity or mortality because of this development of these conditions. And also these fetuses always require neonatal unit admission for observation, or because of the complications that these fetuses are prone for. So the anomalies that we encounter usually include the structural cardiac defects, the neural tube defects, limb reduction anomalies, orofacial cleft defects, diaphragmatic hernia, and omphalocyte. So these are the common defects that usually we encounter in these fetuses. And then the explanation behind the development of these anomalies could include because of the dietary deficiency, in particular the folate deficiency, and also these women, in these women there is an alteration of the in utero environment, and also because of the technical difficulties with ultrasound due to the body habitus, that these, in case even if they have structural anomalies, sometimes we fail to detect these anomalies. So the effect of obesity on fetal condition is the overall morbidity for these babies has increased by almost 8%. So this is a picture showing a macrosomic neonate, and also this baby developed Erb's palsy because of the shoulder dystocia that this baby had. So the fetal effects of maternal obesity usually includes macrosomia, and then the rates of lower Apgar score and the CARD-BH, and then there is reduced chance of spontaneous preterm labor, and then once it is a macrosomic baby, there is always an increased risk of having a traumatic delivery with the result of increased incidence of birth injuries. So there could be fractures, there could be palsies, Erb's palsies, brachial plexus palsies. So all those birth injuries are usually encountered once the babies are macrosomic, and also there is an increased chance of admission to NICU. So the postnatal effects, because the high incidence of VTE that we see in these women should always be advised postnatal thromboprophylaxis regardless of the mode of birth. So even if it is a vaginal delivery or a cesarean section, these women, because the postnatal period is considered to be the greatest risk for development of thrombosis, so ideally the postnatal thromboprophylaxis should be prescribed for all the women regardless of the mode of delivery that she has. And then at least this prophylaxis should be continued for at least 10 days. And in case if this woman, apart from obesity, if she has additional risk factors, they are considered to be having or considered to be as high risk, and ideally the thromboprophylaxis should be continued for at least 6 weeks. And then the breastfeeding, in these women, there will be difficulty in the initiation as well as maintenance of breastfeeding. So this is because of the physical impediments due to the incorrect positioning due to the large size breasts that these women have, and also because of the high incidence of cesarean births these women will have, and because of the increased NICU admissions. So all these factors might contribute to difficulty in initiation and maintenance of breastfeeding. And also the pharmacological mechanism such as an impaired prolactin response is also seen in these women. But anyway, the breastfeeding should always be encouraged because of the established fact that the breastfeeding has a lot of neonatal benefits, and also it helps in the weight loss postpartum, and also it reduces the risk of developing type 2 diabetes in women, particularly who develop GD in the antenatal period. And then the long-term effects that we see in these babies is explained by this hypothesis, that is the Barker's hypothesis, that is this is nothing but the theory of intrauterine programming. So both babies who are small at birth or during infancy, secondary to maternal starvation during pregnancy, have increased rates of cardiovascular disease and type 2 diabetes in adult life. So these fetuses might be at risk of developing even the long-term effects during the later part of life in the form of increased prevalence or increased incidence of developing cardiovascular disease and type 2 diabetes. And these women are at risk of developing anxiety and depression in the antenatal period as well as in the postnatal period. And the prevalence of postnatal depression is 13%. So these women always should be ideally screened for all these mental health issues, and appropriate specialist advice should be taken care. So to summarize, the recommendations with obesity in pregnancy include they always require a proper pre-pregnancy counseling, especially for morbidly obese women. And because some of these women may require bariatric surgery, and once the woman undergoes bariatric surgery, the development of complications during pregnancy may be lessened. So, and also a bit of advice on the diet and exercise with the resulting in weight loss might improve the complications or might have a favorable effect during their antenatal period. So always these women should be provided a good pre-pregnancy counseling, and they should always be given a high dose folic acid supplementation, that is 5 milligrams of folic acid right from first month throughout the first trimester of pregnancy, because these women are at increased risk of developing neurological defects and the congenital anomalies. And a healthy diet and exercise are important in pregnancy, so these women should ideally be referred to a dietitian and advised to avoid excessive weight gain during pregnancy. And then because these women are at increased risk of developing diabetes, they should be considered screening for gestational diabetes mellitus. And they should be ideally have a very early booking visit so that her pregnancy will be properly managed. And then these women, because obesity is a strong risk factor for development of preeclampsia, low dose aspirin, that is 150 milligrams, ideally should be given from 12 weeks till the birth. And then again, these women are at risk of developing thrombosis, so we need to consider antenatal thromboprophylaxis, in particular if they have even additional clinical risk factors for development of venous thromboembolic disease. And then again, because of the congenital anomalies that we see more often in these women, a detailed anomaly scan should be advised so that we can detect whatever anomalies that these women are prone for. And ideally, glucose tolerance testing at the booking itself, and in case if at the time of booking it is negative, we should consider glucose tolerance testing at 28 weeks, and with the potential for repeating it in later pregnancy if it is even negative at 28 weeks of gestation. So ideally, we should always, these women should always be screened for diabetes at regular intervals, even though they turn out to be negative at the booking visit and at 28 weeks. So this is in just about the obesity in pregnancy. Okay, thank you.